Thank you, everyone. Lovely to see some more familiar faces again. Welcome to the Scotland ITP Support Association patient virtual meeting. Our patient expert today is Dr. Catherine Baggett from Glasgow Royal Infirmary. I'm also joined by 4 board members from the ITP Support Association. Rhonda Anderson, our senior patient mentor, and she hates me when I say that. Derek Elston, Anthony Hurd, and myself, Mervyn Morgan, from the ITP Support Association. We've got a really good turnout today. We had a really good turnout last week as well for the England and Wales one. So hopefully this will be as informative as last week's was. Right, has anyone got a question? If you have a question, just put your hand up, or there is on the reactions thing downstairs. Lauren, you're first up.
Thanks.
You got a question?
This is good.
For Catherine, lovely to see you.
You too. Yeah, I do. This is great timing because today I found out that my referral to an ITP Center of Excellence was rejected. So I moved to this area recently and got set up with a local hematologist and who is not an ITP expert. So I asked if it would be possible to get a referral to the nearest hospital, which is the ITP Center of Excellence. And he said, yes, we can do that. Sent the referral. It got lost, chased it up a month later. Finally, they got it. And I called to check today. And the hematology secretary said they got notice from the person doing the triaging there that they would not be seeing me and it's been rejected. So I'm just wondering.
Where are you based now, Lauren? Is it Cumbria?
In Cumbria.
Cumbria, because you've moved from the States, haven't you, if I remember right?
Correct. Yeah, that's right.
Yeah.
Yes. Yeah. So the referral was to Manchester.
Of Manchester, okay. Catherine, any views on this? Can they do that or?
I don't know. So I can really only talk I haven't worked in England now for 15 years, so yeah. I don't know exactly how it all works now. In Scotland, I would have to get it under the radar. Let's say you lived in Edinburgh and you wanted to be looked after in Glasgow. If I put my hand up and said I was looking after a patient from Edinburgh in Glasgow, that would be frowned upon by management. But I would be able to get it under the radar. If I didn't say anything, no one would notice and it would be fine. Okay. And I've got a very, very difficult ITP patient who used to live in my area and now doesn't live in my area, but wanted to stay with me looking after her because I've just been looking after her for so long. And again, that I just haven't said anything to the powers that be that she no longer has a Glasgow address and no one's noticed. And I would just defend it the best I could if it ever did get noticed. It's because health boards in Scotland are paid for their local population. I mean, it is very different in England. So, but just from Scotland point of view, you're paid for the patients in your area. And if you are going to be what they call a tertiary centre where you accept referrals from elsewhere, then there should be extra money to that health board to look after those extra patients. It'll be something similar in England, but England is even more driven by the money being in the right place. Now, you can get around that a little bit if you ask for a second opinion. So if you wanted a second opinion from someone in Manchester, I would hope that would. I'm surprised. I can't believe a haematologist has rejected you. That would be very strange.
May I ask which Manchester hospital, Lauren? Is it Manchester
Royal Infirmary?
Okay, yes. And was the consultant Jekko Tatchell or?
So the secretary said a Dr. Scott rejected it.
Okay. I think if you contact me offline afterwards, okay with the details, I'd see what if I can have a word with Jekko, who is the lead haematologist there.
Okay, thank you very much.
I can't promise anything because, as Catherine said, it is very difficult with different trusts. But okay, is that all right? Yeah.
That's great. Thank you. Yeah.
That's
Anything
good.
to add to that, Catherine?
Yeah, the only other thing I'd say, we actually don't call the centres ITP Centres of Excellence. That I can't. We decided we shouldn't be allowed to. We decided that we shouldn't be allowed to do that because there's no. Although we have now audited ourselves to make sure that we're meeting certain standards, we decided. I think we. I can't. What do we call ourselves? I think just ITP
Specialist centres.
Specialist centres,
Yeah,
or
yeah,
something. It's
yeah,
basically people who've got an interest who
yeah,
look after a lot of ITP patients, but there's no really hard and fast criteria that say you are a centre of excellence.
yeah,
I'm not saying that we're not all passionate about ITP, and we do look after a lot of patients and we get a lot of experience. So, but just to make it clear, what I wanted to say was, it could be that your haematologist in Cumbria knows a lot about ITP and could be really good. And if you were worried after things you'd read or been told that perhaps you felt that you wanted to get a second opinion, then you can definitely do that. And I don't think anyone, I can't believe Manchester would reject you at all.
no.
The only other thing I wondered whether Dr. Scott was not a what we call a non-malignant or benign haematologist, so doesn't specialize in ITP at all. But you think that they would then refer it on to someone who was. So
One
not
would
sure.
thought so. Yeah.
Yeah, for the second, sorry, just quickly, the second opinion, would I need to ask my GP to
No,
refer for that?
actually, no, I think it can be your GP. I think it can be your GP. Yeah. So I've certainly had been asked for second opinions. But so it can be done either way. It can be done through your GP or it can be done through the haematologist. Because I mean, if I have a patient who's really difficult, who says, do you know what, I'd really like to get a second opinion, it's quite reasonable, because sometimes, cases can be really complicated, and the patient just wants to get some reassurance that what's being suggested to them by one haematologist is what another one would. So it's quite fine to have a second opinion.
And if you have a patient who has been a difficult case and then they reach a period of stability, but then have another sort of relapse, I'm wondering, is that second opinion doctor able to then weigh in, or would they be able to in any case? My impression was you have to be their patient in order for them to have anything to do with you.
It's difficult. I suppose what firstly I want to say is we're really friendly. So we have like this thing called the UK ITP Forum, which has got something like 140 members now. And when we have a difficult case, we share the cases. So we all sort of all know all of each other. But it's a really sort of tight knit group. So if any doctor has a difficult patient with ITP, then they will often go to the ITP Forum and ask for advice. So just say it is a bit of a joined up community. If you feel that, don't feel that your local haematologist, may have access to sort of expertise. But to a certain extent, you're correct. You are generally only under one haematologist. So if you're in Cumbria and it's a bit difficult and you get a second opinion from Manchester, then you go back to Cumbria, everything's fine, and then there's a problem again. The Cumbrian haematologist could reach out to Manchester one again. Yeah, but you would officially be under the Cumbrian one, if that makes sense.
That's my fear, that I'm back in the hospital with 0 platelets and no ITP expert on my team.
Sure. It really varies. So it really varies in terms of ITP experience. I think one thing I would say is that people who don't deal with haematologists who don't look after a lot of ITP often find it a little bit difficult if patients are having trouble on TPO mimetics. I think TPO mimetics are a little bit harder to manage than sometimes doctors realize, and if you follow the official guidance, you can run into platelet counts that's sort of going up and down all the time. But there are loads of haematologists out there who do deal with ITP. So if you're new to the country, we have places called district general hospitals and we have teaching hospitals. So even if you're in a district general hospital rather than a teaching hospital, you could still have doctors in that district general hospital who have a lot of experience of ITP. So it really depends who's looking after you, and you might want to find out, what type of haematologist you have. Are there someone that only deals with what we call benign haematology, so ITP and patients who have anemia and things like that? Or have you got a hematologist who mainly does like malignancy, like lymphoma and leukemia, because they'll probably not have much experience of ITP, whereas someone who does benign hematology, they probably do see quite a bit of ITP. So you could find out who your hematologist is, because that will give you an idea of probably how much experience they've got.
Okay, that's really helpful. Thank you.
Thanks so much, Lauren. Thank you. Mrs. Vad, I believe you had your hand up. Yeah.
Hi, everyone.
Hiya.
Hi. I just wanted to ask, my daughter's with special needs and her platelets fell, and she was in hospital for a couple of days, and because she had bleeding from the mouth a little bit and things, bruises and all. And the consultant who came to see that, because my daughter had a clot plaster in her leg, so they're trying to find the balance and all. So the consultant said she needs Rituximab, which
Right.
is Rituximab treatment. And because we had the clinic yesterday with at Hammersmith, this was other doctor, and she said, she needs to have a vaccine for pneumonia.
Mm-hmm.
So we've never been told that before. So and then after 2 weeks they can start Rituximab. They put her on low dose steroids at the moment. But does this vaccine, does it have any side effects like
So this pneumonia vaccine, so it's something called Pneumovax. So when your immune system is suppressed for whatever reason, but Rituximab being one of them, then patients are recommended to get the Pneumovax vaccine. I mean, all vaccines can have side effects, and you might feel a little bit poorly after you received it, have a sore arm, might get a little bit of a fever, sort of flu-like symptoms. Any of you who've had a vaccine before, sometimes you can feel a bit grotty afterwards. And then all vaccines can have really, really, really rare side effects, just like any medication you take. So it's always a balance of risks and benefits. So the concern is that if you've been exposed to Rituximab, then you are at increased risk of things like flu, which can make you increased risk of pneumonia, and hence the importance of the vaccine. And certainly something like the Pneumovax vaccine, I would say the benefits of having the vaccine far outweigh any of the incredibly rare side effects that any vaccine can have. Pneumovax doesn't have any particular concerning side effects over and above, any other vaccine. So, I always, sometimes you just go down this bit of rabbit hole, don't you, in that you need one medication and then you need another medication and you're thinking, oh God, do we really need all these things? But I would certainly be recommending to all of my patients who get Rituximab that they should be vaccinated against pneumonia. So I do think it's the correct thing to do. I mean, I realise you have to make a decision for your daughter, but I would be supportive of what's been recommended.
And because she's a kidney transplant patient, does it affect her kidney?
No, it won't affect the kidney. And I presume she's had a kidney transplant. She's on some immunosuppression already, is she?
Yeah.
Yeah, so it definitely is important. But no, there's absolutely no reason why the Pneumovax will affect her kidney transplant at all. Not at all. All that the vaccine is going to do is it's going to stimulate her body to make antibodies against certain types of pneumonia. So that's what will be happening in her body. And what that can cause is make you feel a bit ill. It's almost like you're having a little bit of an infection because your body is reacting to that vaccine by making antibodies, and that's why people can feel unwell. The one thing, but I don't want this to put you off, but the one thing that vaccines sometimes can do is, because you're stimulating the immune system, is sometimes they can make things like ITP worse. Now, again, it's a balance of risks and benefits because your daughter's having a relapse of her ITP. So, it's I would still be recommending it.
Okay, all right. Thank you.
Okay.
Hard choice.
Rhonda, you got your hand up?
It is. I know it is.
Rhonda?
Yes, I just want to say that I have had a lot of Pneumovax and other vaccines because I had a splenectomy in 2000, and my GP and the nurses and so on and various people looked after me really well and given me the vaccines, and I'm always glad to have them because I think that they are protective. of course, you know, as Catherine has said, you have to weigh it up, and who knows what's going to happen to an individual. But I would always also, as a layperson, urge you to take the vaccine with all the proper advice and take it for what it is, which is the protection. And just recently, my daughter, who has asthma, had a very bad dose of atypical pneumonia. And she was very, very ill and had 3 weeks off work, and, you know, she couldn't breathe and she was in a terrible state, really. We were very, very worried about her. She went to hospital at the beginning, you know, as an emergency in an ambulance. Fortunately, she recovered. But, you know, if you have had the vaccines, it helps you not to get such a severe illness. But there's always that risk, that tiny risk, as Catherine has said. But, you know, as a layperson, I would say, you know, it's better to have the vaccine than not have it, which is also the medical opinion.
Okay, thank you.
Thanks, Rhonda. Okay, any other questions, anyone? There must be some. Gordon. You're muted, Gordon. That's another pound for me. Bottom left.
Yeah, thank you. Hello, this is my first time on here. I was just diagnosed with ITP last March. Now, the thing is, I've also concurrently had a lot of episodes of skin cancers and various surgeries on that. And one of the things which they arise from is a thing called actinic keratosis, which is sort of precancerous damage from the sun. And in the past, I was put on a drug which its trade name is Effudix. Its other name its posh name is Fluorouracil, and that has an effect of stimulating the immune system to fight these lesions. Now, I was told not to take it when I was under steroids, particularly. Now, I've got things at the moment seem to be stabilized on the ITP front. I responded well to steroids, but I've still got this issue of wondering whether I should be taking a topical drug. It's an ointment which has, it works by stimulating the immune system to fight the damaged cells and trying to stop things going cancerous.
So it's not a drug. It's not a drug I use. It's not a drug I'm familiar with. But did you say it's topical to actually apply it to the lesions?
Yes, you apply it to the lesions.
And but it is absorbed into the bloodstream, is it?
Well, I think it must. Well, it's absorbed through the skin. I guess it's going into the bloodstream. Yes.
But it sounds as though the majority of the effect is because you're applying it to the actual lesions. The majority of the effect must be on those lesions, rather than, because sometimes you can take drugs that you rub on your skin that then actually get absorbed through the skin and into the system. And so, although it's not a drug I'm familiar with, the first thing I find reassuring is that it's being applied topically to the area that's affected. So you'd hope that you don't get a huge systemic effect from that on the immune system. I presume it must act locally to a certain extent. Tell you what I'll do is, just while we're on, I'll just have a quick look and see. Could you just tell me how you spell it? The actual name of the drug?
It's FLOU, Flu, ROU, Fluoro, RACIL. It's OU twice.
Okay. Oh yes. Yeah, I found it. Bear with me a second. Is I will look it up afterwards and I'll get in touch with Mervyn and let you know. So basically, but my upshot would be is you're worried that the fluorouracil might cause your ITP to be exacerbated. That, I think that's your concern, isn't it?
That basically, yes, it's is likely to be an adverse reaction on the.
And I think that's very difficult to know. You're absolutely right. Things that stimulate the immune system. I'm not saying it definitely makes your ITP come back, but you're always concerned that anything that fiddles around the immune system could cause it to
Yeah.
reappear. So the first thing I'd say, I presume you're still under the follow-up of a haematologist.
Yes.
Yeah, and do you have a sort of little bit of an open access in that if you have any bleeding problems, you can give them a call?
I do, yes.
Yeah. So I will look it up and I'll see what advice I can give and I'll get in touch with Mervyn. But for now, I'd feel reassured because you're taking it topically, which means I hope that you don't get much systemic effect with the sort of immune system stimulation. And also if you're concerned, if you get any bleeding symptoms, then just call up your ITP centre. But I'll see what information I can find for you.
Right. It's all complicated by the fact that they can hide symptoms of the cancers developing, and so it's very much a sort of juggling match. You get there's a tendency to get slightly different advice from the different specialists handling the different sides of things.
Yeah, yeah.
In the middle, wondering, well, which way do I go on this?
Yeah. So I think I mean I'll obviously just come at it from I'll look up exactly how fluorouracil works, and then that'll enable me to give some sort of guidance as to how it works. Do you apply it as a cream? Is that how it works?
Yes, it's a cream. Yes, powerful stuff.
Right. I will.
Okay, Catherine. If you send me any
self
details to me, and then I'll forward it to Gordon.
Okay, no problem.
Okay, right. Just before we've got a couple more questions now. There's one in the chat, a couple in the chat. A lady's asking, Cynthia, is it correct that also getting your vaccines before rituximab, or at least 6 months to a year after, is the best advice, so the vaccine can work?
Absolutely.
We've had this one before.
Yeah. So you want to have, ideally, you want to have the vaccines before, because what rituximab does is it destroys what's called the B cells, the B lymphocytes, and the B lymphocytes are essential for making a response to the vaccine. So ideally you want it before, and I think it is something like 4 weeks or 6 weeks before you should get your first dose of rituximab, so the body's had its chance to have an effect. If you can't do that, then it's better to wait probably at least a year. So some of you may have been told when you're chatting to your ITP doctors that rituximab suppresses your immune system for about a year. So your immune system is not sort of back to normal for about a year. It gradually comes back to normal. So ideally you'd wait a year to get your vaccines, but I actually think the recommendation is something like 6 months. So ideally before, but otherwise you need to wait a good number of months, ideally probably 12, but I think the recommendation might be 6. But yeah, that's the rationale. Get it before.
Okay, and there's, before we move on to Samantha, who's got a question, there's another question in the chat. David's asking, would it be reasonable to ask about the ITP registry and how it works? Now, what I would say before you answer that, there is lots of information about the ITP adult registry and the ITP pediatric registry on our website, so you can go there. Catherine, have you got anything to add on that one?
Sure. So the ITP registry is a fantastic thing. So ITP, amazingly, particularly for me, was considered a rare condition. And there's so much that's not known about it. For any of you who've had ITP for a long time, you'll know that everyone is different. So the registry was set up so that people could join, and they were giving their consent to have all their details in terms of what their platelet counts have been, what bleeding symptoms have they got, what treatments have they had, what's been effective, what hasn't, and also to give some blood samples as well, which are stored. And then with the information, clinical information on that patient and their blood, then researchers can apply to the registry to use the data, use the blood samples to try and learn more about ITP. And some really good things have come out of it, really, really good things. So you can't automatically join the registry. Your centre where you're looked after has to have joined up to the registry. You have to, because the site where you are has to have gone through their research and development department to get approval for the registry, for them to be able to recruit to the registry. So all the specialist ITP centres have to recruit to the registry. I've had people who really want to be in the registry but aren't on my site, and I've let them come and see me once, and then they can do it. So if you're not actually looked after at a specialist centre but really want to join the registry, then generally you can try and work around that. So yeah, registry is a really good thing. If you get the chance, please join it.
If I may just unmute just for a moment. So I'm linked to Inverness, and when I sort of looked on the map, Aberdeen looked like the nearest proper place. I wasn't. I've not bothered my hematologist by asking about it because they've got they're too busy dealing with other things yet. So is Inverness, is Regmore, does that count as a part of the team?
I don't think Regmore signed up. You can be signed up to recruit the registry and not be one of the specialist centres. So if you look on the map of the specialist centres, you may see that Regmore isn't there, but doesn't mean they're not recruiting to the ITP registry. So I'd certainly ask your local haematologist in Regmore first.
Yeah.
You know, if you really want to join, then he or she may know where the nearest centre is that's running the registry. And you know, you may be able to be if you're happy to do a bit of travelling, you may be able to.
It's 3 hours drive to get to Regmore.
For you, so, 3 hours drive just to get to Regmore. Oh goodness
me. Yes. Near me is a wonderful tool.
Yes, right. Yes. So does your GP do your blood tests and then you just do the attend anywhere for the appointment?
Yeah. I do the blood tests at the local GP.
Yeah, very
and
good.
Ideally we time it so then the next day I have a video chat with the haematologist.
One of the really good things that came out of the pandemic, that was.
Yeah, it's even better. I had to go on emergency steroids, which knocked out my immune system. I then got some cellulitis. That meant I couldn't go to a booked meeting to Inverness because I would have had to drive. I said, I can't do this. Can we do it over video? And we've done it over video every time since.
That's good. Much easier for you. Yeah.
So 2 weeks of antibiotics for the cellulitis was worth it.
Okay, thank you, David.
Right.
Thank you for that.
Yeah.
Next one, Samantha, you got your hand up?
Yeah, my daughter was diagnosed with ITP in September. So I'm still learning about it. Being 12, obviously she's under a paediatric haematologist, which is very rare. So we actually have a haematologist and a paediatric, so because we can't obviously get the combination. I think she has been on triasamic acid for the bleeds, and did have a count of 1 for a number of months, but they do appear to be now rising, and because she's a child, they don't treat at this stage because it is very early in terms of months. I think what I'm conscious of is she's of menstrual age, and we are having symptoms in the last few weeks of that, the signs of that happening. And although she's not on triasamic acid at the moment, it's what do I expect? Now, she is an open patient with the hospital, so we can obviously call and be there and treated immediately. But it's just, is there anything that I need to be aware of? Because that's quite a big change for her.
Sure, that's really tough. Can I ask what our platelet count is now? She said it was coming up.
Well, we go back tomorrow, but it was 88 on the last count.
You don't need to worry at all. Anything over 50, she'll be absolutely fine.
Yeah, I do think I'm not sure whether tomorrow will be the same or not, because she has had a couple of bruises and a couple of gum bleeds. So whether it stayed the same, I don't know. So it does sort of hokey-cokey quite a bit.
Okay. So anything over 30, she shouldn't have too much of a problem with her periods.
Yeah.
Anything over 50, it won't be contributing at all.
Yeah.
It's obviously hard anyway, because the first period can sometimes be really heavy anyway, and you know, so if she's sort of starting to go into remission, that is reassuring. Tranexamic acid can be really good for periods when you've got a low platelet count. This will be really hard if it's her first period, but what I generally recommend to women is that if they know their period's about to start, they start the tranexamic acid before they actually see any bleeding, because you're then catching it really early. So the bleeding has started, but you haven't seen it yet. Now, if it's your first period, though, that's so hard to tell, because, you know, So I presume the pediatrician, the hematologist, I mean, particularly the pediatrician, will be very aware of like first periods and people who've got bleeding problems and stuff like that. Have you spoken about this already to the pediatrician and the hematologist about the fact that she might start menstruating soon?
Yeah, the haematologist is asking that every month because she goes in every month for testing. The paediatrician, we're only seeing for the first time on Monday. So that'll be a new conversation for us to have with them. So yeah, I'm hoping we'll get some guidance on it. But you just become a bit anxious, don't you, if something that's
and certainly if her platelet count was 1, there would be a chance she could have a really, really heavy period. And, you know, the question then would be is, you know, do you have any steroids at home and stuff like this? But I might need to put my hands up and say that, you know, I don't look after children, so it's not my area of expertise at all. I think it's important just to have those conversations with your pediatrician and hematologist, you know, every month as you're doing. But if the platelet count's greater than 30, it should be fine. It shouldn't contribute.
Brilliant. That's reassuring. Thank you.
Okay. Just before we go to Bonnie, Samantha, Anthony's put a good point in the chat. We have got a number of good videos for ITP with teenagers and children on our YouTube channel, which may answer a few of your questions. So,
brilliant! I've not looked at that.
Yeah,
So
yeah. Have a look. You know, we've got about
associated.
100 odd videos on there with different things. So, okay. Bonnie Brown, you got a question? Bonnie, your hands up. No, right.
So there's quite a lot of things in the chat, actually.
There is, yeah. I'm just looking now. There's another one. A 4-year-old son has ITP and has also lost 2 teeth. The 3rd tooth is about to fall out. The permanent teeth are not pressing them out. Doctors and dentists can't explain this. Have you heard of similar cases before? I'm assuming. I've never heard of this with ITP. I'm not sure if you have.
Oh, I don't think it's linked to the ITP.
No.
I would say it's not linked to the ITP at all. So yeah, I don't know. Don't know. It's not related to the ITP.
Okay, good one.
I think Bonnie's, just to say, Bonnie's still trying to, I think.
Yeah, Bonnie's trying to come back in now. Bonnie, are you there now? No.
No. Oh,
no, right.
Yeah, I think she's coming in and out, I think, actually.
Yeah, she is, yeah. There's another one, Tina Tucker. Want to advise people, really. She had avatrombopag given to her last October when her platelet count dropped to 3. After only 4 days, she was rushed to A&E in extreme pain and found to have blood clots in her aorta, both adrenal glands and 1 kidney. I was frustrated as no one would listen when I said there was a risk of blood clots, especially when her platelet count was over 360. I now have adrenal insufficiency and my kidney figures are worse. So basically, please ask to get your count checked regularly if you go on this drug. My case was yellow carded at her request. Have you heard of this with avatrombopag? I know it's only been in about 2 years now in Scotland, isn't it? So
yeah, goodness me, that's really, really tough. That's really, really tough. So so the avatrombopag rarely works that quickly. I don't think I've ever seen it work that quickly. One thing I always say to my patients is the ITP in itself puts you at increased risk of blood clots, unfortunately. It's rare to see them when the platelet count's very low, but I mean, it can happen. We think that's because the platelets are very, very, very overactive. Because patients with ITP, as I'm sure you know, you make platelets with no problems at all, but they get destroyed too quickly. So all the platelets that are circulating in your bloodstream are very young, active platelets rather than old platelets, because most platelets last for about 10 days. So that's why sometimes people with ITP or platelet counts of 1 don't bleed at all, because the platelet counts they do have work really well. So, you know, having a blood clot in your aorta is, you know, my first reaction when I saw that was, you know, is there something else going on? You know, it's not just the ITP, but there's some other thing that's giving you a tendency to have blood clots in your arteries, because that's very, you know, we're talking about blood clots in the arteries rather than the veins. And that's, you know, that's really, really unusual. And I hope you sort of had a few investigations to find out why you had them. Because it's a platelet count of 3 to 360 in 4 days is very unusual, and generally we'd check the platelet count once a week when we first start someone on a avatrombopag or L-trombopag or romiplostim. We generally wouldn't do it more frequently than that. So I think it's really good it was yellow carded. I think, I'm saying I've never seen this, and therefore it's really important that it's yellow carded in case it has happened to other people. So I'm, really sorry to hear what you've been through.
Okay. Tina, have you got anything you want to say on that one? No? Okay. I think Bonnie's back with us. Bonnie?
Yeah, so sorry. I just changed device. My iPad
That's
decided
okay, no problem.
not to let me touch anything.
Good question.
Anybody, really interesting because mine was going to be about AMPAG. So I'm 40. I've had ITP for years. Started at a platelet count of 1. Did steroids, then Rituximab, then went on to L-trombopag in a very short period of time because nothing worked. That worked for about 18 months. Then it stopped. So then I went to Nplate. That worked for 18 months. Then it was COVID, and I was about to go on a clinical trial, but COVID came along. So we went back to L-trombopag just randomly to see what would happen, even though I didn't respond to it after 18 months. And I responded. And that was now at the beginning of COVID. So that's 4 years, well, 3 years I've been back on L-trombopag. Now, I know that loads of people are saying avatrombopag is, sorry, this now contradicts slightly the last comment, but lots of people have been talking about how it's a bit of a wonder drug because of the dietary restrictions, have iron infusions, so that creates my gut is saying stay on L-trombopag while it's working, and when it doesn't work anymore, then go on to avatrombopag. Although my consultant's like, amazing new drug, how about you try avatrombopag, which I do feel I should be excited by, but I feel a sense of dread. And I just wondered what your opinion would be.
Sure. I think if something's working, don't change.
Yeah, that's what I'm thinking.
And
it is yeah.
So the thing, the difference between L-trombopag and avatrombopag, that there's no head-to-head comparison of them. So there's no evidence that avatrombopag is better than L-trombopag. The thing, and you're absolutely right, the thing that's so much nicer about avatrombopag is that there's no dietary restrictions. It can be, it doesn't have the effect of some patients experience some liver inflammation, and it can be used in people with quite severe liver disease. So there are advantages, but if I've got a patient on L-trombopag who's coping with all the dietary restrictions and it's working well, I would whoever said, if it isn't broken, don't fix it, as says Tony. So
yeah, I totally agree. It's just that sort of stopping eating by 6 or 7 and going out for dinner is a bit of a not. Yeah. All of those actual social sides of things. I'm a bit of a recluse anyway, so it fits my lifestyle. But should I want to be social, it's a right old bummer because I eat like a child because they're like, oh yeah, Bonnie needs to eat really early, doesn't she? And that's fine.
Sorry. Avatrombopag,
go for it.
Avatrombopag works in the same way as L-trombopag. So there's quite a high probability that you will respond to it. So I think it's a balance of risks and benefits. If you are happy with the situation as it is now, then I wouldn't change it. If you're not happy and you would like to be able to be sociable beyond 8 o'clock at night, then you could give it a go. But with all these things in medicine, it's all a balance of the risks and benefits. So I think it's how much it's affecting your life.
Yeah, but the inverse is the horror of your platelets going up and down, even when you change to a new drug to find the new dosage. That's horrifying to me. So like I'm very much like I'm on 75 milligrams of L-trombopag, and I sort of maintain around 50-ish. Sometimes it goes better if my stress levels are lower. So I kind of think let sleeping dogs lie as well. But that's really helpful. Thank you so much.
No problem at all.
Thank you very much, Bonnie, and I'm glad we got your question in the end. There's another question in the chat. Sorry, Catherine?
Perfect. No, I was just going to say, someone somewhere way back has asked, I'm sure a couple of times, about exercise It's Helen.
Oh, there was one. Yeah, yeah.
So I just realised we'd missed
Helen,
it.
yeah. I'd like to find out about exercise and ITP. How much exercise is too much, e.g., running depending on platelet levels?
Yeah, I mean, I think so we say, you know, no semi-professional rugby or anything like that, but basically you can exercise. I always say to my patients, I'm really happy whatever you do, as long as you're not putting yourself at risk of injury. So, you know, for example, if you were someone, I don't know, who ran up hills that were covered in boulders, I might sort of say, well, you know, maybe be a bit careful doing that. But if you just want to run, it's not a problem at all. The only thing that you might find, so when people, if your ITP is not in remission, you've got a platelet count of 10, and you did a lot of running and you get very sweaty and all your blood vessels dilate, you may get petechiae. So you could find that could happen, but it's not dangerous. So exercise is fine as long as you're not going to injure yourself. And if you're not in remission at the time, you might get petechiae, but that's not a dangerous thing.
That is what happened to one of our members. He's actually a patron, Olympic runner. He did qualify for the last Olympics, but had to pull out because he was diagnosed with ITP through running, and all the petechiae started and the bleeds. So yeah, which is a shame.
Oh, that's horrible.
It is, yeah. Got a question in the chat from M. Stewart. Should every new ITP patient be screened for immunoglobulin deficiencies? And what does this involve?
Yeah, so we do recommend that because there is an incredibly rare condition where you don't have any immunoglobulins that's associated with ITP. It's a simple blood test, and it should be done with everyone when they're first diagnosed. So it's just a blood test. We just check immunoglobulins and we make sure that it's basically antibodies. So there's three main types of immunoglobulins: IgG, IgA, and IgM, and it's just simple blood test. They find out what your levels are, and I don't think I've ever seen any low ones in my entire career. So yeah,
good stuff. All right, and Tina's just put a addendum onto her question. She's now under a thrombosis specialist hematologist, and now she's been put on rituximab to control the platelets, whilst also on anticoagulants as well. So yeah,
so very tricky. So very tricky.
Yeah,
and that's the thing, is that, you know, on one hand, you want to have a platelet count that's good enough so that you can be anticoagulated on the other hand. So it sounds like you're under the right person, though. You're under a thrombosis specialist, and you know, it's people who specialize in thrombosis and, as I say, these more sort of benign conditions that are going to have more experience with ITP as well. So I really wish you all the best.
Good stuff. Bonnie's on a roll now. She's got her hand up again. Bonnie,
I've got my laptop going. Yeah. No, it was just about the IgA. I've got an deficiency, and they've just sent a sample to this lab. It needs to go to their card or something. I really have to then get a card, but I don't know what it really means. Like, what does an IgA deficiency mean? Because I don't think I can do anything about it.
Right.
Or can I?
You're cutting out a little bit, but I think you were asking, apparently you've got a card that says you've got IgA deficiency. Is that right? Yeah,
well, soon I'm going to get one, but what does that actually mean?
Sure. So this is not did they find it when you were when you got diagnosed with ITP?
No, my second specialist centre did.
Right. So there are some people out there who have IgA deficiency. It doesn't cause you any harm on a daily basis at all, or at least very, very, very rarely. But the one thing it can cause is reaction to blood transfusions. This is why you're being given an IgA deficiency card. And the reason for that is that so you've never seen IgA. Your body doesn't know what IgA looks like because you don't have any. So if you receive blood from a donor, that bag of blood probably contains some IgA in it. And when your body sees it, it'll go, oh my God, what's this strange foreign protein I've never seen before? And you can react to it. Now, the vast majority of people with IgA deficiency do not react to blood. And the recommendation these days is, yes, it should be known that you've got IgA deficiency, but you don't need any special blood or anything like that. You just get a normal blood transfusion, but it's recommended that when you're getting that blood transfusion that you just monitor a bit more carefully. And if you do have any sort of allergic reaction, then you start getting specialist products. So they may wash the red cells. They generally don't these days actually use IgA deficient donors because they're just rare as hen's teeth. But that's what it's all about. It's not doing any harm to your health, but you have this card so that people are aware that you are at slightly increased risk of having an allergic reaction to blood than other people.
And why would you test under ITP? Is there a link around?
Yeah, so the link is with this condition. I'm going to get it wrong. Congenital variable immunodeficiency. It doesn't. Combined variable immunodeficiency, CVID, is linked to ITP, which is when you have very few immunoglobulins at all, and you're at very, very, very high risk of infection. It's normally diagnosed in people at a young age. You don't have
anything you can do to, so what, there's nothing that improve my ITP by correcting the IgA stuff?
No. The two probably in you aren't linked. It's only this common variable immunodeficiency, which is when you have very little of any antibody and you're very seriously unwell, and it's a really, really bad problem. You have just been found coincidentally to have IgA deficiency.
Okay, brilliant. Thank you.
I don't think there's a link between IgA deficiency. I can't see why there'd be a link between IgA deficiency and ITP. So I don't think there's any evidence that the two are linked. Whereas with the
so why do they test for it? But why would they test for it if there was no link?
For everything. So when you test for immunoglobulins, you test for IgA, IgG, and IgM because you're looking to see if someone's got an immunodeficiency in all of them. And so as an incremental finding, you'll find, oh, this person hasn't got any IgA. They're IgA deficient. So they haven't been testing for IgA. They've been testing for all the immunoglobulins.
Bro, thank you.
Thank you very much, Bonnie. Right, there's another question in the chat. We're going into the last 10 minutes now. Cynthia, wondering if is there any experience using MMF alongside the TPO and or a rituximab? I've had my second round of rituximab after 2.5 years. It took longer to take effect this time, so my consultant added MMF. And I think we've had a few questions like this in the past, which is okay for me. I've just lost a bit now, then. Bear with me. I seem to need more than one medication, so also am on avatrombopag since August. I used to be on avatrombopag. Both of them worked fine for me. Avatrombopag seemed to stop working, but have had my numbers go up and down on both after the first rituximab stopped working. I'm a bit confused there, but
it's okay. It's okay. So I mean, just to sort of stick to Cynthia's first point, have I got any experience using MMF alongside any TPO and or after rituximab? So I mean, it sounds like you've been on a very, very long journey, having all sorts of medications. I commonly use a TPO mimetic with a drug like MMF or rituximab or azathioprine, because, and this is for people who are resistance treatments, is that what you're doing there is you're using your TPO mimetic to stimulate the production of platelets, and you're using a drug like MMF or rituximab to suppress the immune system. So you're tackling the ITP in both ways. You're trying to prevent the body from breaking down your platelets too quickly, but you're also stimulating platelet production. And I find it often very, very effective. So my common treatments would be steroids, no response or lose response, TPO mimetic, lose response or don't respond very well, and then I'll add in, and then, you know, with the agreement of the patient, add in something like mycophenolate, because it can sometimes work really well. And the story you give about, you know, sometimes things work, sometimes, you know, some things work and then they stop working. It's incredibly common in ITP that patients will respond to medicines and then lose that response, and then other things have to be tried. I see it all the time. So I think so I think now if you're on avatrombopag and MMF, that sounds like a very reasonable combination. And it says now your platelets are 200, and that sounds like great success.
Thank you very much, Catherine. Anthony Lochner, you was on MMF, wasn't you? Or you are still?
Yes, I mean, strangely, I also had rituximab back in 2010 and 2013, and rituximab worked well for me on both occasions. I got about 2.5 years remission both times, but after the second drop, if you like, in 2016, we went on to MMF, and I've been on that ever since. So platelets are normal basically now. They're always around the 140 mark, something around there on MMF at the lowest possible dosage, really, which is 2 times 250 milligrams a day.
Very
So
good.
that's it. But the only other problem, of course, there are immune suppressing drugs. So to bear in mind that one is vulnerable to just about anything and everything that that is out there. So one has to take that into account.
Cautious.
But,
Yeah.
particularly with things like shingles or pneumonia, they're the two difficult ones. But anyway, that's my experience. So
Yeah.
hope it works.
Thanks, Anthony.
Yeah, I think the other thing I'd say about rituximab as well is that it's a really, really effective drug against ITP, but it generally loses effect over the period of about 5 years. People are very, very lucky if they go into a complete remission and never relapse again after rituximab. So I always say to patients, if your rituximab is effective for at least a year, I consider that to be good. But it's effective for less than a year and definitely less than 6 months, I would generally recommend something else because you're probably not going to get long-term remissions from it. Oh, here's a good question. Yeah, remission.
The last question: what level of platelet counts as being in remission?
Yeah. So I think there's lots of things to consider here. So if I have a patient who's got a platelet count of greater than 30 and they're not bleeding and they're not at increased risk of bleeding, then I will try and get them off all medication because you don't want to have anyone on a treatment that they don't need. We know that a platelet count of greater than 30 prevents any serious spontaneous bleeding. So, and anything over 50, you can have major surgery on. So I feel that we should consider that normal, and we shouldn't fight for a platelet count that's greater than 150, because the theory is that through evolution has given us bucket loads of platelets, so that if we lose them when we get attacked by a lion, it won't matter because we've got that reserve. So there's that thing I wanted to say, but the other thing I wanted to say as well is that if you do have a platelet count over 150, and this particularly applies to people over who are on TPOs, if your platelet count is over 150 and it's like that for over a year, there's definitely room to consider stopping the medication because it could be that you've gone into a spontaneous remission. And again, another reason to see if you can lose the medications that you're on. So I would say to anyone with ITP, aim for a safe platelet count. Don't aim for a normal platelet count.
Yeah, and as has just been put in the chat, the key is to treat the symptoms and not necessarily the count. Yeah.
Absolutely. Yeah. So, I've had patients who have had platelet counts of 1 and have never bled. So you have to be really, really careful about what you do. Now, there aren't many patients like that, and we do like to have them more than 10. But
we've got a patient here, Derek Elston, was in single figures or just into double figures for years and never bled. Did you, Derek?
Yes, that's true. I had a count of 10. I was on immunoglobulins for quite a long time. But the time between each infusion got less and less and less. And in the end, my hematologist said, well, take you off and see what happens. And the answer is nothing happened. So I lived very happily for 10 years with a count of 10. Unless I needed some surgery, and then they'd boost it up. But that only happened a couple of times. But then I went on to avatrombopag so I could have a heart bypass and never looked back.
Excellent.
Now around about 150. So I'm very lucky. But I never bled, and I didn't bruise very much.
And this is, I think I can end this session by saying that's why the ITP registry is so important because everyone is different. And what we'd like to be able to learn is, well, what makes some people bleed? What makes some people resistant to treatment? What makes some people go into spontaneous remission? You know, there's so much we don't know.
Okay, there's one last question before I close. Got 2 minutes. So should we all have our doses lowered every now and then to see what would happen to the platelets?
So if someone on a cheaper mimetic has a platelet count of less than 150, that says to me they've still got ITP, but we're keeping under control with the cheaper mimetic because their platelet count isn't normal. So I would be reluctant to fiddle around if the platelet count is less than 150, because that patient has still got active ITP. Having said that, if a patient really, really wants to reduce the dose and then we kept a close eye on it, I wouldn't be completely averse to it, but that's my general rule of thumb. But if someone has a platelet count of greater than 150 for more than a year, I give them a trial off the cheaper-mimetic, you know, and monitor them every week to see what will happen, because they could well be in a spontaneous remission and nothing will happen to the platelets. Again, discussing with the patient. So if the patient has got a platelet count of 170 and just does not want to run any risk of rocking the boat, fine, we'll just keep it going. But yeah, I wouldn't fiddle around with the doses without being very careful, and probably definitely not if you haven't got a platelet count that's normal.
Thank you very much, Catherine. I think on that note, I think we're closed. My huge thanks to Dr. Catherine Baggott from Glasgow Royal Infirmary for fielding all your very, very excellent questions. Before I do close, just to give you some information about other things coming up. In February, we've got another one of these virtual meetings, the All Ireland meeting with Dr. Gerard Crotty from the Midland Hospital just outside of Dublin. Then in the 1st of March, we've got an in-person event at the Liner Hotel in Liverpool. You can book tickets for that via our website. And then don't forget, on the 11th of May, we've got our annual convention in London. And I've just been finalising with Professor Newland today the agenda, and I will be sharing that with the board members on Thursday, who's on the agenda, before I share it here. But we've got some stellar names coming as well. So excellent stuff there. Thank you, everyone. As always, we will try and post the video of this on our YouTube channel in the next day or so. But thank you for taking the time. Thank you for asking some excellent questions, and I hope you all found it useful. Thank you very much.
Bye, everybody.
Bye.
Thanks a lot. Bye-bye.
Bye, Catherine.
Thank you, Catherine.
Bye.
Bye.
Cheerio, everyone. Take care.
Dear Anthony.